I see that there's my first question maybe, Lynn, about your study, the fact that you have a very high proportion of women compared to men, and if it would, you think, may have biased results or not?
I think when I was talking to my supervisor about this, I think just generally they found that women are more likely to come forward and talk about anything to do with psychosocial. So that, yeah, I guess you could say that the results are dominantly from a female perspective, but in my actual dissertation, there's obviously a lot more, detailed quotes and things about certain things that men had commented on or spoken about as well.
Jessica Kushner in the chat wanted to know about negative psychological triggers. Please, Jessica, ask a question.
Yes, hi, thank you. Yes, in listening to all the exciting studies and research that are going on, of course, makes me think about contacting patients. But, I want to also be sensitive that even just hearing from me, especially sort of out of the blue and when maybe I'm not aware of what's going on with them currently, if there is any concerns we should have about, a negative trigger from just hearing from someone.
I think, I'm sorry, I think from what I heard from my participants, they were just really, any communication, positive communication with a healthcare professional, they very much valued. And you could see that, for those of them that had absolutely no trust or faith, it was because they didn't feel like they'd been heard. So I can imagine if they were given the opportunity to be checked in on or spoken to, obviously I can't speak for them, but I can't see that would be a negative trigger as such, because of how important that awareness and understanding and support from healthcare professionals was. I don't know if that directly answers your question, but.
Yes, no, that's reassuring. Thank you, appreciate that.
Shane, I wanted to know about age at diagnosis and other remarks.
Yeah, yes, I was curious if any patterns were elicited regarding age at diagnosis, just anecdotally. I agree, I see what you talk about. We have lots of depression and anxiety and fears in our practice, but I see it significantly more like when a teenager is diagnosed or a young adult. They seem to have really elevated levels of fear and anxiety versus the young kids, even though they have sort of a more cautious childhood in some families, not in all families, which is great. They seem, just because they've grown up with it and it's part of who they are, they seem much more stable from a mental health perspective.
Yes,
but
I agree. I agree. And I think when I mentioned age of diagnosis as well, I think for a lot of them, for those that had been diagnosed at a younger age, especially those that were diagnosed, like you said, around teenagers, they were a lot more, you could see that they were a lot more impacted by the condition. So they wouldn't do certain things. They were very much more cautious about it. Whereas those that had grown up with it were very much like, I've lived with it for this long, I've made it this far, I can do this, and that. And I think when you mentioned about their families as well, that does play a big part in how much they can do, because obviously naturally their parents are quite protective, but in some ways that can have a negative effect because their child is then very cautious. Whereas those that diagnosed later on in life, like 30s and their 40s, they had the view that, they'd made it that far, they'd done all those things in their life without a diagnosis and been able to live relatively okay until they had, whatever event led to them having their diagnosis. And I just thought it was really interesting because, it just goes to show that at different times a diagnosis can really have an impact on how you manage that condition.
We are taking a last from
Thank
Hal,
you.
asking if the psychological consequences that you analyzed were are not influenced by the presence or absence of family history.
So I'm wondering if children that had a parent with vascular EDS and therefore had a role model might have done better, or if a parent died when a child was very young and the other parent became excessively protective, might that have a detrimental impact? Did you do anything to assess those types of issues?
I didn't, but those were things that definitely came up in the interviews. So like you said, if there was a family who, say, mum had the condition, and one example, she had a son. She was very much on, ensured that her son lived his life in the best way possible, and commented that she tried not to limit him doing things, tried to encourage him to do things with his friends, etc. But there was one family who had lost a family member to vascular EDS, and that the participant I was speaking to felt that her other parent did protect her way more than maybe she would have been if they hadn't lost that family member. So I definitely think those are factors that would influence, their opinions and the way that they felt.
Did you by any chance get any comments concerning when they learned of their diagnosis and what impact did that have at that time on their lives?
Yes, so for the younger ones, well, actually, no, for all of them, a lot of the, each and every one of their stories were different. But for those that were diagnosed later, it was either as a result of after they'd had their children, so they had quite traumatic pregnancies, and it was, through that they then had the investigations and eventually got their diagnosis. And the comments around that were more around, it was obviously a huge shock to the system, and then they had that worry that their child would also be affected. But for those that were diagnosed younger in life, especially in their teenage years, they spoke about being scared, and there was this fear. There wasn't necessarily, relief of finally knowing what was wrong with them. It was actually accepting the truth that they do have a life-limiting condition that, could lead them to die early. So there were definitely some comments around diagnosis as well.
Thanks, Sarah. Very, very interesting results. Al, you had a first question from Al.
Well, thank you. This was a really wonderful talk. I was wondering to what extent obstetrics practices might influence some of your observations regarding gestational age and birth weight, especially since you saw that affected mothers were showing at least trends to have children that were born earlier or at lower birth weights. How much of that could be driven by scheduled C-section or scheduled induced labor because of concerns about the maternal health?
Yeah, so thank you for that question. That's a really good point. So what we saw was that for the so there was one woman who she was responsible for 3 of the pregnancies. She was an affected mother, and we saw that with her first pregnancy, anecdotally, she had placental abruptia, which eventually, that with another event, led to her diagnosis. And from there, it was planned C-sections, but otherwise wasn't. For the other 3 births, none of those women had a diagnosis at that time either, and at that time had the event. We had very limited details. This was mostly, again, quite a bit of chart review by myself personally. And so we had very little details, as I don't believe any of the children were born here at our center. And so with that, it can certainly be different depending on the obstetric practices. I'm not entirely familiar, again, with the obstetric practices among this population, to be honest. But as far as our group goes, none of these women were aware at the time. But I can imagine, yes, it would change their practice and change the outcomes and how they deliver.
I mean, there are certainly obstetricians who decide in at-risk women with vascular connective tissue disorders to induce early delivery. So it's something that needs to be controlled for.
Al, can you hear me?
Yes.
Yep.
It's Melissa Russo. No, I completely agree with you. And I think that's sort of a limitation of this with the retrospective review, is that trying to tease out whether this is iatrogenic versus spontaneous preterm birth is really the biggest question. And I think that's, they're working on a bigger study to sort of look at this and then try to really tease that out, because I think that's going to be key to this. I mean, when it's the fetus that's just affected, I think the mechanism potentially is that the collagen or something in the membranes is what's causing them to go into labor a little bit early. But I completely agree with you that we need to figure out whether this is iatrogenic versus spontaneous.
Thank you.
Shane, you wanted to comment on that?
Oh, I was just commenting also, I totally agree with the point, and that's why Sarah did the separate analysis of those that were prenatally diagnosed, those that were affected versus non, but even in the non-affected moms, the rate of preterm delivery was quite high, and that was a large proportion of the population, and none of those children were diagnosed prenatally. So, so I think it's still quite significantly higher than the normal population. So as Melissa mentioned, we suspect that there's some abnormality with collagen in the amniotic sac.
I thought 71% of people with preterm labor were, preterm delivery were born to affected mothers. Did I miss that? Did I read that wrong?
It was that 71% of affected mothers had preterm labor, had preterm birth. But of those that had unaffected mothers, it was, do you want to show that slide? Of unaffected mothers, it was 38%, I believe, or 39% that had preterm. So this is percent that had preterm delivery.
Sorry. There we go. Go back here real quick.
So in Melissa, in the normal population, it's what, like 15% for preterm delivery?
Yes, I believe so. I can go back to that one real quick.
Yeah, it's 15 to 20% typically.
Melissa or Sarah, in the known affected, you're not allowing those mothers to labor, I presume, correct?
It all depends if their diagnosis is known.
That's what I said, yeah, and then known mother.
The general consensus, not really from the study, is just that we, for multiple reasons, don't want people to labor because of uterine rupture, but also because of the risks with lacerations that can occur at delivery that are very difficult to stop.
Thank you very much, and thank you for being late in Moscow, I suppose, among us. So my first question may be, obviously, the problem of the unknown significance of the variant. For this particular patient, did you have any minor signs of the disease, especially in terms of the not only on the face, but skin and other small signs like that from any inherited from the father?
I don't see father, but the patient hadn't typical vascular phenotype. She has typical classical phenotype. It's problem for her personal management for pregnancy.
Had you the opportunity to look at the imaging of all the arteries to see if there was any lesions for this particular patient?
Particularly?
The vascular imaging of this patient, have you done it by either CTA or MRI?
Yes, she has hematomas, and her father has aneurysm and dissection of vascular.
Okay, but did you investigate this particular woman for aneurysm or lesions at the for arterial lesions in the abdomen or cervical or whatever?
It's now she hasn't have vascular aneurysm.
Okay. Michael, or you wanted to ask something in terms of presentation, similar patients reported previously?
Yeah, we have there were similar patients. Maybe Niti, she's also there.
Yeah, I'm here.
Oh, Niti, please.
Yeah, so we presented 9 families back in 2019 with exactly these glutali pathogenic variants, and we saw a very similar phenotype to the story you've given, with significant emphasis put on the hematoma formations and the surgical intervention required for those. Some vascular and digestive abnormalities and complications too, but perhaps with a slightly milder phenotype than your typical classical vascular patients. And then the features that you see in the skin that are very typical of classical EDS, with the skin hyperextensibility and scarring to a certain degree. So really interesting cohort of patients. I was listening to Madeline's talk and I wondered whether any of the, looking at the biobank, I was wondering whether any of those could have come up through that, or the haplo insufficient, because they are a sort of milder phenotype, that they weren't mentioned. Thanks.
Thank you.
Needy, in the ones that you and others published, the progression to the characteristic vascular abnormalities is really not quite the same as it is in the ones with the substitutions for glycine splice-site mutations that are seen in the other people with the more characteristic vascular EDS. And I wondered whether these mutations really should be put into the same realm. They really look like they have a somewhat different phenotype.
Yeah, I think that certainly could be the case. I think we need more families and to see the sort of variability of these patients and families.
Thank you again. Very nice presentation. So we have 5 to 10 minutes for an open panel discussion before a break. So on these particular clinical outcomes, do anyone wants to raise questions, remarks, or synthesis about the phenotype of VEDS?
I have one question about the last presentation in this really fascinating series of patients. So I might understand why these patients might have atypical or less severe vascular disease, but the addition of extensive joint and skin abnormalities that are atypical for vascular EDS and more typical of classical, is there any mechanistic hypothesis that anybody can think of as to why specifically these mutations would cause, a gain of those phenotypes? I'm having trouble coming up with even a concept as to why that might be.
I'm not sure that it was investigated. I suppose that you might probably think about the fact that you are creating a lysine and that this can be the hydrolysis. You can also maybe think of a possible heterodimerization with COL1 or COL5, which is favored by this particular missense variant, but I have no personal investigation on that. Maybe Needy or Michael or Peter have an idea?
I don't have an idea. I'm quite interested to know.
I mean, the stability of the triple helix is a consequence not only of the hydroxylation of the prolyl residues, but also charge interactions along the length of the triple helix. And this changes the glutamic acid to a lysine. So it dramatically changes the external charges and the charge-charge interactions. I think so on the outside of the molecule, these are all facing outward residues. So I think that from there, it almost certainly deals with interactions and interactions with what is not clear. But one possibility, and I think a couple of these are either at or near platelet interaction sites. And that would account for changes in the vascular stability without necessarily changes in leaking and sudden a different kind of bleeding and bruising than would be seen with the things that activate the signaling pathways, that these may be less likely to activate the kinds of signaling pathways that are seen with the other kinds of mutations. But I think that it may have to do with that and whether they affect platelet function, and so you get the muscular hematomas and the significant skin bruising, and the changes in the physical characteristics of the skin as well. They felt different to me than the classical EDS. The skin has a little different feel to me, but
Are these all clustered or the same missense variant, or
No.
are they the same substitution but widely scattered?
Needy, why don't you talk
In our
about the
cohort,
distribution?
there were a couple that were repeat, and one big family with another family that was repeat, but otherwise different throughout the triple helix.
So that would argue against the specific interacting partner being disrupted, wouldn't it?
Well, it depends how many interacting sites there are for any given class of molecules. I mean, the collagens interact along the entire length, so that would be one of the things. But
I mean, this is Ulrike. We have a whole bunch of them all scattered along the triple helical domain. But what I always noticed, and I could never explain, that all of them affect an X position. So I don't remember that paper that Needy mentioned, but I wonder, is there a logic behind it always affecting the X position, at least in our experience?
Yes, it was always affecting the X position, but I don't know the logic behind that.
Yeah, but I find it interesting, there are glutamic acids at the Y position. Why are they not affected, or why do their substitution not lead to a phenotype, as far as we know?
Yeah, and all of them leading to this quite specific phenotype that's quite different from both vascular and classical EDS. I agree.
Yeah. I don't know how.
Collagen autoantibodies ever been described?
Well, the Goodpasture syndrome is, are classical autoantibodies against type 4 collagen. So, and some of the rheumatic diseases have antibodies against type 2. I'm not aware of antibodies to type 3 or to type 1.